Let's move on to the next section, consequences of alcohol use disorder, withdrawal. One of the immediate consequences of patients with alcohol use disorder is the emergence of withdrawal when consumption of alcohol is reduced or stopped. And as we all know, this is part of the diagnostic criteria. So most patients with alcohol use disorder will report, some degree of withdrawal when they reduce or stop their drinking. The good news is that the majority of alcohol withdrawal is self-limited and mild in nature, typically emerging within 6 to 12 hours after the last drink. But we can think of the withdrawal coming in 3 sort of domains: neuropsychiatric symptoms, autonomic symptoms, and then motor disturbances. And all these things include like anxiety, headaches, nausea, sweats, agitation, and tremors. If left untreated, these symptoms can persist for several days or more. The subjective symptoms can be quite distressing. And then, of course, cravings can become pretty strong during this time as well. But in terms of managing the withdrawal, the first day or two after they begin to emerge is the critical time when individuals need to be treated. And this is also the time frame that the individuals are most at risk for withdrawal seizures if they are going to occur. Typically tonic-clonic seizures that occur in single seizures or in rapid bursts. But for some individuals, the most feared consequence of alcohol withdrawal is really the progression to delirium tremens, or DTs. And this really occurs in the context of poorly managed withdrawal. And it's really a medical emergency that absolutely requires hospital-level treatment. In many places, it's ICU transfer. And DTs are characterized by severe symptoms, which can persist for up to a week if untreated. And patients are really toxic looking. They're highly agitated. Vital signs are highly irregular. And patients are extremely high risk for negative outcomes. Historically, before adequate treatment was offered, mortality rates were as high as 30-40%. Today, it's sub 1% level. So in the hospital setting, this is well managed, but still it's considered a medical emergency. One of the challenges of DTs is that we actually don't have a good way to predict it. The majority of patients who have DTs have severe alcohol use disorder and really prior history of DTs, which turns out to be the strongest predictor. But otherwise, we actually don't have a good way of predicting. And therefore, the mainstay of alcohol withdrawal management is early, adequate treatment. If you do that, that should really limit the chances of progressing to more severe forms of withdrawal, including seizures and DTs. So the mainstay of treatment of alcohol withdrawal is pharmacologic treatment with benzodiazepines. Of course, there are many other agents that are used in today. Phenobarbital, for example, is gaining a lot of interest. There are anti-epileptics, anti-seizure medications which can be used, or alpha-2 agonists, which include things like clonidine or dexmedetomidine. So the symptom trigger therapy is when treatment is provided only if the symptoms are severe. That would indicate that some type of medication may need to be administered. But if it's lower than that, then you actually just simply continue to monitor. And this is considered perfectly appropriate and evidence-based way of managing alcohol withdrawal. Ensures that those who need pharmacologic treatment will get it, but those who don't need it because it's only mild withdrawal actually don't receive anything. Because benzodiazepines on its own can actually be problematic if it's given to people who actually don't need it. And so this is considered a safe, appropriate way to use this. For the most part, especially for mild to moderate withdrawal, as needed or PRN administration of these medications like benzodiazepines or phenobarbital or even anti-epileptics using something like the SIWA, which is a gold standard withdrawal monitoring tool as a guide. However, those who score high on the SIWA or those who are already delirious or those who have prior history of DTs actually would not be suitable candidates for the symptom trigger therapy or the SIWA-based approaches. Another example of individuals who should not be placed on SIWA are those who are unable to report their symptoms. So people who are intubated, unconscious, or somehow verbally unable to communicate. SIWA is actually never appropriate for those patients. For those patients, a fixed dose regimen of some type needs to be administered. Some type of fixed dose regimen is predetermined how much they're going to get and provide a standing regimen and a taper. Another iteration of a fixed dose regimen is to do what's called a loading dose, where you actually give IV doses of things like diazepam or phenobarbital, which are very long-acting agents, on day one, and then simply let it self-taper or provide a tapering dose of the medications. So the bottom line, symptom trigger therapy is a default approach unless there are certain contraindications, in which case a fixed dose regimen is recommended. Symptom trigger is a more reactive approach, which is considered reasonable for low to moderate risk patients. And really, the fixed dose regimen is a proactive way of managing, and that's why it's reserved for those more at high risk of withdrawal. So key points for this section is that alcohol withdrawal is usually mild and self-limited in nature. But for some, it can progress to more severe withdrawal, which is prevented by adequate early treatment, which is a gold standard approach. Now, symptom trigger therapy using things like the SIWA tool is considered suitable for the majority of patients.